Welcome back, everybody. Whoop. Can you turn me up just a little bit? Am I good? Whoa. In case you didn't have a double espresso after lunch, here I am. So welcome back, everybody. Thank you, and we'll get started now. For the folks on the phone, thanks for your patience. Our next session is Dr. Colleen Kraft, presenting on the Healthcare Personnel Workgroup.
Hopefully I can figure all of this out. Right, is it this one that I use? Thanks, either or. Okay, so I just want to remind you, good afternoon, that the findings and conclusions herein are draft and have not been formally disseminated by the CDC and should not be construed to represent any agency determination or policy. All right, you're hearing about the Infection Control in Healthcare Personnel Workgroup. And so the goal was to update the guideline for infection control in healthcare personnel, which was recently 1998 updated. And so we are providing the information for Section 2, all of that updated information. So this work group will focus on, and does focus on, pathogen-specific issues for infection control in healthcare personnel. Where information is out of date, the work group will make updates using evidence-based methods where evidence is available. So the Section 1 of this recommendation is the infrastructure and routine practices for occupational infection prevention and control, and that was published in October of 2019. And so now we're into Section 2, which is epidemiology and control of selected infections transmitted among healthcare personnel and patients. And you will see over and over again that we're sort of highlighting at different times, obviously, different pathogens. So diphtheria, group A strep, meningococcal disease, pertussis were all published in November of 2021. Rabies published November 2022. You can see the link for that. So our current status report is that we are in progress on measles, mumps, rubella, and varicella. Those are completing clearance and then will be posted to the Federal Register. Pregnant healthcare personnel section is posted to the Federal Register for public comment until June 26, 2023. So we welcome your comments. And cytomegalovirus, parvovirus, B19, and conjunctivitis, the draft recommendations are being presented and hopefully voted on at today's meeting, and pending approval will go into clearance. Staph aureus, although there is a lot of literature on Staph aureus, some of our discrete questions, we're still waiting on a literature review and to figure out how to get that information out of the literature. The ones that you will hear about soon will be scabies pediculosis, hepatitis A, bloodborne pathogens, which include Hep B, Hep C, and HIV, herpes, tuberculosis, and gastroenteritis. So now we're going to go into the draft recommendations for these sections for cytomegalovirus, parvovirus B19, and conjunctivitis. The narrative sections to support these draft recommendations are in progress, and the CDC subject matter experts have provided some initial input on the draft narrative. I'm going to talk to you about the 1998 recommendations, but I want you to immediately forget them because I'm then going to present the current recommendations, but we thought it was important for you to be able to compare what we did think and what we're thinking now. So for 1998, it was do not restrict personnel from work who contract CMV-related illnesses. This was category 1B. Ensure that pregnant personnel are aware of the risks associated with CMV infection and infection control procedures to prevent transmission when working with high-risk patient groups. That's category 1A. And do not routinely use workplace reassignment as a method to reduce CMV exposures among seronegative pregnant personnel. So the current draft recommendations for discussion and hopefully voting today are that 1, work restrictions are not necessary for healthcare personnel who have an exposure to cytomegalovirus. Number 2, work restrictions are not necessary for healthcare personnel with active CMV infection. For recommendations about healthcare personnel who are pregnant or intending to become pregnant and exposure to cytomegalovirus, please see the pregnant healthcare personnel section, which is available for public comment. Again, going back in time to 1998, the parvovirus B19 recommendations at that time were to ensure that pregnant personnel are aware of the risks associated with parvovirus infection and of infection control procedures to prevent transmission when working with high-risk patient groups, as Category 1B. Then do not routinely exclude pregnant personnel from caring for patients with B19. So this gets a little nitty-gritty, so I'm going to read all this to you, but this is perhaps where there'll be some discussion and questions. So for asymptomatic healthcare personnel who have an exposure to parvovirus B19, they may continue to work, remember, including providing direct care to patients at increased risk for complications from parvo B19 if they wear a source control device, for example, a face mask or medical mask. I know we talked about that. Actually, I'm just reading this verbatim. For 14 days after their last exposure. Symptomatic healthcare personnel who have had an exposure to parvovirus B19 within the 14 days and have signs or symptoms of the prodrome of parvovirus B19, which include and are not limited to fever and a cough, they should be evaluated by occupational health and safety. They are suspected or known to have acute parvovirus B19 infection, they should be restricted from work for 5 days from the onset of their symptoms until they have been fever-free for at least 24 hours, whichever is longer. If fever is not resolved or other prodromal symptoms are not improving after 5 days, they should be reevaluated by your occupational health group. And upon return to work, if respiratory symptoms have not completely resolved, they should continue to wear a source control device until resolution of their respiratory symptoms. Again, for recommendations about healthcare personnel who are pregnant or intending to be pregnant, please see the pregnant healthcare personnel. All right, we're going to go back in time one last time to conjunctivitis in 1998. Restrict personnel with epidemic keratoconjunctivitis or purulent conjunctivitis caused by other microorganisms from patient care and the patient's environment for the duration of symptoms. If symptoms continue longer than 5 to 7 days, refer personnel to an ophthalmologist for evaluation of Category 1B. So there was a literature review that occurred, and there's a debate in the literature about work restriction duration led to a decision to conduct this literature review. So basically, is it 14 days versus duration of symptoms for epidemic keratoconjunctivitis? 14 days is different from the 1998 recommendation, so the work group wanted to confirm no harm recommending duration of symptoms. Question was developed by subject matter experts to address the appropriate duration of work restriction for adults with conjunctivitis working in healthcare settings. Resultant key question was vetted and approved by the Healthcare Infection Control Practices Advisory Committee. Key question: for adults with conjunctivitis working in healthcare settings, does work restrictions for duration of symptoms compared with work restrictions for 14 days prevent transmission of conjunctivitis in healthcare settings? So in terms of the study selection process, 849 potentially relevant studies were identified. 2 were a duplicate. 847 title and abstracts were screened. 782 were excluded as not relevant to the key question. So that left us with 65 full-text articles. 56 of these were excluded. 27 were not relevant. 14 were not primary research or systematic review. 6 were not in English. 4 had no healthcare worker included or healthcare personnel. 3 had overlapping populations, and 2 had no full text available. So that left us with 9 that are included in the analysis. So 1 observational and 8 descriptive outbreak studies implemented work restrictions as one of the multiple sequential or concurrent infection control measures. Duration of work restrictions varied from duration of symptoms to 10 days or 14 to 15 days. Both methods helped end outbreaks. All methods helped end outbreaks, but 10 to 14 to 15 day work restrictions were lengthened when healthcare personnel still had active conjunctivitis. So healthcare personnel may be able to return to work earlier and may need to be restricted longer than 14 days, so just showing that there's sort of a great variability in this syndrome. Cost savings were inconclusive and staffing shortages were definitely not addressed, partly due to the time of, like, the years that these things were. In one outlier report, transmission ended after implementing screening and furloughing of asymptomatic healthcare personnel. Both methods would have failed. So evidence is insufficient to warrant a change in recommendation. So the draft recommendations presented today are for healthcare personnel with purulent conjunctivitis, including epidemic keratoconjunctivitis, exclude from work for the duration of their symptoms. I would like to acknowledge this fantastic team. We're very much going to miss Elaine Decker. We welcome our new individuals. So thanks to Hillary Babcock, Vicki Brown, Ruth Carrico, Nicholas Daniels, Elaine Decker, Michael Ann Priest, Mark Russi, Connie Steed, Michael Tapper, in memoriam, Tom Talbot, and David Weber, and of course the CDC support group with whom we could do none of this work are here, so thank you. Right, now to the fun part. Any discussion, comments, or questions?
Thank you for that. We have Erica Shinoy.
Just a quick question on the parvovirus one, and are you defining specifically the populations at risk for infection? Because I think part of the recommendation has to do with who they're able to care for. And then there was just a minor point on this was will you write with fever-free in the absence of antipyretics for 24 hours, just for clarity. We often will do that in our recommendations because if someone's on Tylenol, we wouldn't want them to say that they've been fever-free.
So I think what you're referring to is the asymptomatic personnel.
Yeah.
And so I think, I don't think we're defining populations at risk because I think sometimes we don't know all the populations at risk, right? We kind of maybe treat all patients like they're the population. So we'll have to talk about that. David, looked like you were going to. Okay. And then your second question about fever-free without antipyretics. I think rather than say that in each individual one, I don't know if there's like a more global way to say that. David Kuhar looks like he's near a microphone.
Yeah, and I'll just add for populations at risk. So I think what you were asking is whether we were going to restrict based to be sure that they didn't interact with just those at risk for severe or complications from parvovirus.
It was more the practical part of that the patients are distributed across healthcare settings, and it may not be very obvious right at that point. And so because it labels them, like how are they going to be identified?
Yeah, and that was actually why we didn't make it specific just for those who are at risk for severe disease. And I think a part of the discussion in masking everywhere they go is we didn't feel like we could really ensure that they didn't interact with people who are at risk for complications when practically implementing this, if that makes sense.
Okay, just the way it was written is as if they are, let's say, including providing direct care at risk. So,
because we're believing that the masking is mitigating the transmission.
okay.
But remember, they're asymptomatic. So if they're symptomatic, they're not at work.
Mm-hmm.
Then the antipyretic part, I think we can decide if we want to pull it out as sort of a or
I was just going to say, I think we have that in the text. It's in the text of the document, just not in the recommendation itself, because the more clarifying words we added, the longer it got.
within the narrative and not within necessarily the actual high-level recommendation.
I'm looking around to see if anybody else has comments. I don't see anything on the phone either. Last call. But I think you're good. Dr. Kraft. So we are galloping ahead. Dr. David Kuhar is taking the stage and will be raising another ad hoc topic for our committee to hear about today and decide about. Oh, and before I forget, so as with the previous discussion about special pathogens, after the next break, there will be an opportunity for the committee to vote on each of the small things. So please be anticipating that as you think and talk to each other over the course of the next hour or so. And that includes both the healthcare personnel information and what we're about to hear about now. And the special pathogens, all of the above. Just foreshadowing that so you're not caught by surprise. And with that, Dr. Kuhar.
Thank you. All right, so I am going to talk about proposing an update to one recommendation, just one, in the Protective Environment section of the Guideline for Isolation Precautions 2007. And I expect this to be a brief presentation. I'm just going to briefly describe kind of what happened, what we saw the problem as, and the proposed update. And so first, to just acknowledge, Guideline for Isolation Precautions 2007 is currently being updated by the HICPAC Workgroup, but I think as we saw with the presentation earlier, they're working on earlier parts of this guideline and haven't yet, I think, gotten far enough ahead to the Protective Environment section. So in May, we, the end of the public health emergency prompted medical centers for a number of actions, but among them was updating policies for the use of. And as they were doing this, at least some apparently were reviewing recommendations that were already out there and beyond what was posted in pandemic guidance, and we had concerns expressed about one of them in the protective. So this is a screenshot of some of the recommendations in the Protective Environment section of the Guideline for Isolation Precautions, and as you can see highlighted here, under the use of standard and transmission-based precautions in a protective environment, number 6F3, barrier precautions, for example, masks, gowns, gloves, are not required for healthcare personnel in the absence of suspected or confirmed infection in the patient, or if they are not indicated according to standard precautions. Now, this recommendation is also reiterated in slightly different words in also Appendix A, Table 5, which summarizes actions for a protective environment. And in Part 2 here and highlighted under standard and expanded precautions, it's sort of restated. Gowns, gloves, mask, not required for healthcare workers or visitors for routine entry into the room. So the concern, was that this recommendation was being interpreted by some as indicating that masking for source control in a protective environment is simply not appropriate, and that this was being used to apply to even periods where there could be increased respiratory virus transmission in the area. And even beyond that, that if masking in a protective environment where our most vulnerable patients are was not needed, being used to say that perhaps we don't need to mask in other areas of health. So, a proposed option for addressing this was perhaps deleting the recommendation and the Appendix A sort of restatement of it, pending further section review by the work group. So this would be, in essence, spot welding, a one-point fix here before the work group has advanced. So it would be deleting the recommendation there, 6F3, as well as that Appendix A, Table 5 statement. In doing this, from the Protected Environment section, this would remove recommendations on when to not wear personal protective equipment in a protective environment. This would not affect when personal protective equipment is recommended in a protective environment. However, I noted about here, it's important to think through the unintended consequences from deleting a section, and that's prompt. Essentially, that is the issue. So please feel free to discuss, and I'll do my best to answer any.
Dr. Shinoy?
Sorry. So I think one of the unintended consequences is because the protective environment is about risk of fungal infection, right? It's all built around that. that I imagine when it was originally written, it was to ensure that we don't keep adding PPE to these interactions, because we know that there are downsides for adding PPE and people end up using gloves as a substitute for hand hygiene or other reasons. So I imagine that that's why it's there. And so I think one of the unintended consequences by deleting this is to think about, are people confusing the rationale for what a protective environment actually is? It's about protection from fungal infection, for which this PPE is not indicated except as for transmission-based precautions. I think separate from that is the issue of source control, which would live in other policies that a hospital or a facility might consider. So I think there is an important role to state that extra PPE is not indicated for the reason that you have someone in a protective environment. There may be other reasons for use of PPE related to source control separately from that.
Thoughts about?
While you're thinking, I'll just frame this again as one of those adventitious moments, not to be disrespectful to the process of updating the isolation guideline, but rather, having had flagged by colleagues in the field that this is causing problems, can you please fix it? And being sensitive to the reality that really during the peri-COVID, intra-COVID period, creating resistance to something as helpful as source control among healthcare personnel seemed like a really bad idea. So we're trying to get that out of the way until we can come back and consider this further. Mike?
Thanks. I think Dr. Shinoy's comment is important. I guess I do want to clarify, I guess, if we can get clarification on just what the protective environment is intended for, what kind of pathogens it's protecting. I think that'll help to frame the conversation a bit. Is it fungal infections? Is it other things, to help?
So do you mean which patients are you placing in a protective environment, or what is it protecting patients?
Yeah, I guess what pathogens are we concerned about? It does sound like perhaps we're talking about multiple pathogens, and it's more about the host than the pathogen, perhaps. But I think just looking at this, it's a little bit out of context, maybe, and so it might be good also to have that background for our discussion.
Gotcha. I don't want to speak out of turn. I would rather I'd had it prepared with what we had from isolation precautions to put up in a slide, and unfortunately I don't. My impression was that this was intended to protect patients beyond just our most immunocompromised, such as et cetera, and that it was intended for I thought that I was intended for a virus protection.
I think there's a conflation here of a couple of things. There's the environment itself as built and designed and maintained, which really is what Dr. Shinoy is pointing out about avoiding, the delivery of air loaded with fungal spores or perhaps bacillus. It's the same thing that we do when there's a construction site nearby, right? Only more. On the other hand, from a healthcare personnel delivery perspective, there is reason to believe that somebody who requires that specialized environment might be at risk for a worse outcome or a more complicated course if they are infected. And so source control in that context seems to be not so much about the fungal issue, but more about the respiratory pathogen issue. That said, I'm interested in hearing more about Erica, what you were saying about avoiding piling on too much PPE. That's always something that is a practical reality. But then again, it is 2023 and, source control remains a thing. So I'm curious what people think about that. I'm seeing various nods and looks across the room. Chris.
Thank you, Mike. And David, thank you for bringing this up. I think it may help to just be clear with people what the recommendation is, and is it are we talking about source control, or are we talking about about something else. So practically, in our healthcare system, we have groups who want to put their patients in protective isolation or reverse isolation, and I never know what that means. And so, and it varies, right? People do all kinds of things from gown and glove to gown, glove, and mask. So just clear guidance if it's wear source control, and when respiratory viruses are circulating, that's a clear message. Practically, though, that's going to be all year round, though, right?
Hillary?
I think, sort of going in a similar direction that I agree that there are some potential unintended consequences, as Erica outlined, in terms of people do sometimes think that patients that are at high risk for fungal infections that you might put in a protective environment based on that, and people sort of randomly think, well, they're really sick and they're immunocompromised and we should put them in a protective environment even if they don't all quite know what that means. There is a tendency to think like they'll be safer if I wear gowns and gloves into that room, even though we don't necessarily think that that's true. So I wonder if what we're really trying to say is that these precautions are not required in the absence of suspected or confirmed infection in the patient, or if they're not indicated according to standard precautions, or if not being worn for source control. And then, like, we've called out that, like, that's explicitly what we're trying to say. Like, you may need to wear source control in these rooms, but that doesn't mean you need to wear all these other things. And maybe rather than just taking these sections out, we could sort of say what we're actually trying to say, which is if you need a mask for source control, that's not what we're talking about right here.
Proposal to modify the recommendation. Add source control as a reason.
Jenny?
Just piggybacking on that, I'm actually looking at Appendix A online and the rest of it, and it does say essentially the statement about the gowns and gloves not required, but right after that it does say use of gowns, gloves, masks by healthcare workers and visitors according to standard precautions as indicated, kind of what Hillary was referring to, for suspected or proven infections for which TBP are recommended. So I think perhaps that gets to that point.
More, actually. More context surrounding the recommendation.
And I was reading from the slide afterwards, and it says it right underneath. There we go.
Yeah. I believe that
Yeah,
is
I think,
also a reiteration of one of the.
yeah, I think in that same place we could say also, like, as indicated for suspected infection or as needed for source control. I think if we just use the word source control, people will feel better.
Yeah, I'm reading that last bullet as in the patient to protect the healthcare person, as opposed to the reverse, which I think is the concern.
One fix to that second, to that highlighted bullet could simply be similar to the recommendation.
When you indicate that it could be an exception, is that inferring it is a recommendation to use source control in this population, or?
The intent here is definitely not to provide new recommendations about when to implement source control, but rather to leave it as an option. That was the concern about this, is that it was forbidding.
Based on what folks are saying, it does sound like that there is sufficient lack of clarity in the way it's worded at the moment, and that it is causing some form of problem, and that we might want to add a little bit of an amendment to clarify. It doesn't sound like it needs to be particularly extensive, but it also doesn't sound like we need to remove this piece entirely. Fair? Judy?
So could we just add to that highlighted line right there, add a comma? So it would say, gowns, gloves, masks not required for healthcare workers or visitors for routine entry into the room, comma, with the exception for the use of masks for source control when indicated. So it's not saying across the board you should always be wearing a mask either. We could add that when indicated or something like that, some verbiage like that.
And so I would say we can absolutely modify this. I'm trying to think through if anything else would need to be added as well for context. And we would have to also, if you can go back one slide, we would have to update the recommendation, the foundation for that statement. And so I think the key here would be this. And it sounded as if the proposal was to keep the wording of the recommendation and add to it, or if they're not indicated according to standard precautions, and something indicating or intended for use for source control, to be sure that we're not suggesting that you recommending source control here, but leaving that option open. I might just consider a little.
We have flags from Colleen and then Sharon. You're not out of the woods yet, David.
I think seeing this in context a little bit better makes, I think what is being proposed is to delete something that makes it more open. So I think that's right. So we want to delete this 4F3 and then the previous one that you said, so that if people need to be wearing gowns, gloves, masks for any reason, they can.
Well, I would say that, this recommendation leaves open transmission-based precautions and standard precautions as a reason for using personal protective equipment. We want to be sure that source control, if the facility wants to do that there at times during the year, is also covered and allowed. And so that's really the intent here, is to leave this, it's a do no harm.
Yes.
leave this as an option.
So I support your recommendation, because I think this has been wielded as a way that has actually increased transmission in some of these vulnerable patients because they see these guidelines. So I think that's my understanding of why we're looking at this again.
Yes, we had been told that this was being used to essentially justify not having source control done, even when people thought it might be appropriate.
I would support that.
I wonder whether it would be helpful, I mean, our group, the Isolation Precautions Work Group, meets every other week, whether we could try to wordsmith this for you and send it back. I don't know if you need a vote on this today, for sure.
I think the hope was maybe to get something up for a vote and get this squared away. One option, we have time right now. We're running an hour ahead of schedule. So if there's a possibility of sort of ironing out some language, and then we can vote on it right after the break, that would be ideal. Before we do that, I see Paul has his hand up.
Thanks, Michael. In regard to messaging, I think one of the things that we've learned over the past 3 years from the patient community is clarity matters. So if you could think in terms of what the objective is that you're trying to achieve, and then think of it in terms of a patient impact statement. I know this is targeted to medical professionals, but inevitably the customer is the one that gets the most impacted. So in the plainest language possible, what is it you're trying to achieve? I think that would be helpful. We've been at the tail end of miscommunications across many federal agencies and across many healthcare administrators and systems. So, again, for the person who is not familiar with how to deal with an organ transplant patient or a dialysis patient who's in a setting and a healthcare professional is making a subjective judgment about whether they do or don't have to, and the patient then has to self-advocate for protection.
I'm sorry to interrupt. You're breaking up every other word, and it's getting hard to understand what you're saying. I'm so sorry. I'm not sure if it's on this end or your end.
Yep. How's that? Any better?
And Paul, your comments about clarity of language came through, and I think it was after that we couldn't quite hear.
No problem. Let me try it one more time. What I'm trying to do is encourage the clarity of messaging, because in the practical terms, the patient ends up being the self-advocate if they're in a healthcare setting where there's lack of clarity among the professionals. And so if you're an immunosuppressed transplant patient,
Paul, you're frozen. I'm seeing reaction things, but I'm not hearing you, and you're not moving. But I do appreciate the point that I think you're making. So the clarity of what we write, so that there isn't confusion amongst the healthcare personnel, will help make it easier for the patients to advocate for themselves and not get stuck. Okay, and your thumbs upping, perfect. we use primitive technology, but we got it done.
Thank you.
I'm hesitant to ask this, Laura, but do you think there's a way to edit a slide in real time as we talk? And Hillary's also saying we could take a 15-minute side break and sit at the table and do it that way. That might be far less painful given our connectivity issues. All right, let's do that. It is approaching 2 o'clock. Why don't we take the next 20 minutes? And then we will go back on microphone at 2:20.